Welcome to Healthcare Algorhythm. I'm Dr. Will Strimel. If you want the real story behind today's healthcare challenges and the strategies and technologies people are actually using to solve them, you're in the right place. Short conversations, clear insights, practical takeaways. Let's get into it. Hey everyone, Dr. Will Strimel here. Great to have you back with us in the Healthcare Algorhythm. With us today is Greg Sciarra. He's the Chief Operating Officer of Embrace Prevention Care, which is a company that is focused on helping older adults with complex medical conditions take the preventive steps they need to stay independent, reduce hospitalizations, and safely age in place. Now, Greg has over 30 years of experience across many domains in healthcare, from senior level pharmacy operations to value-based care delivery. And now he's bringing that to the world of healthcare startups. So Greg, thanks for joining us.
Thank you very much. Thank you for having me.
Absolutely. Now, you and your team are taking on a big problem in a challenging population, and that is keeping older adults, especially those with cognitive impairment, out of the hospital and in the home. So maybe just start with telling us a bit about Embrace Prevention Care, what led you to the problem, and how you and your team are setting off to solve it.
Yeah, thank you. So in Embrace Prevention Care, the problem that we're trying to solve for is, if you think about our healthcare system, everything's more urgent and episodic. Something happens, I go to the physician. So we're trying to come at the problem completely differently. When you actually look at the healthcare continuum, over 19 million hospitalizations by Medicare patients are actually preventable. So how do you prevent it? It sounds easy. So the problem that we were trying to solve for is exactly that. How do we actually help seniors learn healthy actions that start addressing the chronic conditions to address the types of things that their physicians wanted them to do, with the sole focus of keeping them out of the hospital? So we started about 6 years ago in Delaware and Pennsylvania, and we've been seeing patients for actually about 4 years now clinically as we kind of built the model. And in those 4 years, we just recently ran our data, and we've been able to show that we can actually reduce hospitalizations by over 40%. Now, it says easy, but again, it's a lot of motivation, and it's a lot of follow-up, and it's a lot of understanding how do you actually help patients really want to take those healthy actions that actually start addressing their chronic conditions.
So I would imagine, everyone has a unique circumstance, and there's going to be unique factors that would lead them to these healthcare events. However, in some ways you have to standardize it. So maybe just talk a little bit about the model and how you came up with it, and what have your learnings been over the last couple of years?
Yeah, thank you. So a lot of our model we've actually affectionately stolen from geriatrics. So we've built our model on a lot of really good, geriatric principles as an example of what matters most. And the simple fact of that is, we wind up asking our patients, what matters most to you? And my mother knows I talk about her, so she's not a patient of ours, but she knows I use her as an example. But what we try to really do is understand what is the most important thing to her. So my mother is 87, she's in New York, and when we actually talk to her, the number one thing that she wants is she wants to be around for my youngest nephew's high school graduation. So why that's important and what plays into our model is, as we're trying to motivate patients to get better exercise, change their diet, hydrate better, take their medications, when they start pushing back on us, we now know what they value. So again, using my mother as an example, when she doesn't want to do those things, I always remind her, I'm like, Mom, you want to be around for Damien's high school graduation. This is how we're going to wind up doing it.
So you really link it to their individual why, so to speak.
Exactly. Yeah, that's a perfect way to put it. And that's how we kind of really individualize it. Now, as far as the delivery goes, we're flexible. So we provide everything by, through virtual care, through telehealth. About 80% of our patients will actually do this strictly just over the phone. We do prefer video, but over the phone works. And again, a lot of it's really just motivational. So one, we meet the patients where they're at. We do it from the comfort of their home. We have flexible scheduling so that, using you, Bill, as an example, we would find out when you want to actually talk to us again. You'll also have the cell phone of our nurse practitioner. So if you need something, you can actually get a hold of us. So we're trying to flip the model and really make it much more patient-centric, almost like a retail establishment where if you need to go and get your prescription, you go into the pharmacy. You don't need an appointment. So, we've been able to do that. And that's kind of really one of our key tenets. What we do, though, by using a nurse practitioner is we're actually monitoring all of, our patients' chronic conditions. And one of our secret sauces is patients will never learn 10 different things. So when I know that Greg has diabetes, and if I know he has hypertension, and if I know he has CKD as an example, what are one or two things that kind of cut across all of those conditions that actually really make a difference? And then that's what we really focus on. And some of our our patients will actually tell us affectionately we're a pain in the butt, because we will continue to harp on, did you drink enough water? And, sometimes we actually have to call our patients every single day for 5 minutes to make sure that they're actually going to grab that glass of water until it becomes a habit.
Now, do you provide, or where in terms of the clinical spectrum, right? I imagine there's clearly physicians, other nurse practitioners, specialists involved. Where do you fit?
That's a great question. So we're more adjunctive. So the way that we've been operating, and I'll explain about the Medicare's guide program in a little bit, because that's really where we're at right now. What we've been doing, we were directly partnering with primary care providers and we were working directly with them. So anything that we did, we were working within their EMR. We were documenting so the primary care provider actually had full visibility. One of the things that we don't want to do is we don't want to fracture healthcare any more than it already is. So everything that we were doing were with primary care providers, and that's actually how we were originally getting our patients. So again, back to your question, we're more adjunctive. So we let the primary care provider diagnose. Even though we have nurse practitioners that could prescribe, if we have recommendations, we're going back to the primary care provider, letting them be the true quarterback for the patient so that they're really driving everything. We're just there as an extra set of eyes and ears for them, is kind of how we generally explain it both to the patients and to the physician.
And so, since you brought it up, maybe tell us a little bit about that guide program, because I wasn't aware of it until I started researching for the show.
Yeah, so it's a wonderful program. Medicare launched a 8-year pilot back in 2024. It's called Guide, and it's for patients with dementia. And what Medicare is really trying to prove in this 8-year pilot is that by providing not only additional care to the patients themselves with dementia, but also really focusing on their caregivers, that through those two efforts, you can actually keep patients safely in the home. You can improve the quality of life of the patient, you can improve the quality of life of the caregiver, and you can actually keep those patients actually out of a skilled nursing home. One of the biggest things that, is out there that a lot of people don't realize, my family does because my father had dementia. Caregiver burnout is one of the biggest reasons that patients actually wind up in a skilled facility. It's not that they can't be home, it's just that there's nobody to actually care for them anymore. So a lot of this program is really designed around how do you avoid that caregiver burnout? How do you actually help that caregiver to really understand what they need to do, provide additional support, again, with the goal of improving their life, but also keeping the patient in the home.
I'd love
So
for you to talk a little bit more about that, because the caregivers, the family members, they are often the forgotten part of the healthcare delivery team. And so, maybe if you don't mind, just going a little bit deeper on that, how do you all provide that support specifically now if we're thinking about the caregiver? And like, what is it how did you determine what they need?
that's a great question. So again, Medicare's done a really nice job designing this program. As we enroll patients, so the good thing is there's actually no formal referral needed for a physician. So patients and caregivers can sign up for this program directly. There's no copays for this program. So again, Medicare's done a really nice job removing the traditional barriers. As we're enrolling the patients, one, we have to focus on what's the level of dementia for the patient, but specifically to your question, we actually will start off with there's an assessment called the Zarit Burden Index, the ZBI. It's a 30-question assessment, which really is asking that caregiver very specific questions about what are they worried about? Do they feel like they have enough money to actually take care of their loved one? Do they feel like the home is in good shape? So again, it's a really good a good tool that we use. Once we enroll the patient, we then actually go deeper with those caregivers. So we've got a good starting point, through this required assessment through Medicare. Then what we actually do is we actually have our social workers interview our caregivers for about another 30 to 45 minutes, starting off with that ZBI interview, but then kind of really branching off into, all right, Bill, you told us you were, worried about your financials, but what does that really mean? So then as an example, we can actually connect them to an elder lawyer that specializes in elder financing and figure out if there are different ways that we can kind of do it. So we start off with that ZBI, we go deeper. And then the other thing is, and it's just human nature, the more our nurse practitioners and social workers interact with those caregivers, they start opening up more and more and more. So over time, you start even learning more about what they really need that you never knew before. So always actively listening and kind of understanding. It's like, oh, wait a minute, you just told me that. We've never talked about this before. So now let's go ahead and figure it out. So we're constantly updating our plan, not only for the patient, but also for the caregiver, and really trying to kind of assure them that they have a voice, and they actually have support for themselves.
Sure. They can feel like they're on an island for sure, right? Because they're managing so
Absolutely.
their own lives. And often they're not even in the same location or town, that their family members are, but somehow they get wrapped up into being accountable for making decisions and understanding, what's going on with mom or dad or grandma. And so like, along those lines, I imagine you all must have learned a lot in these last, several years of putting such a program in place, because every family, every senior is going to be somewhat of a new experience. If you think about your team, so you mentioned nurse practitioners, social workers, I'm sure you've solved a lot of them, but what are the pain points that you guys are continue to face? Or, maybe even a little bit of both. What's been solved over the last few years, especially if you think about in the terms of technologies that have helped, and what's still a struggle and what's still a pain point?
Yeah, no, it's a great question. So, some of the things that we've solved for is, again, figuring out how do you actually, in general, motivate patients. I mean, again, the being grounded in the geriatric principles of what matters most and several other things actually allows us. That the example I used of my mother before. So, really making sure that we're bringing it back to something that really resonates with the patient. Because if you just tell them, "Hey, you got to take your medications," that's what we tell patients all the time. And as a pharmacist, I've said that thousands of times, but it never really works. So, we've really learned that we've got to stay on it. Two, you're never truly fully done. So even though I may have a patient consistently doing chair exercises now as they watch The View, which is a very real thing that we do. Again, we kind of link into things that people do. We're constantly still following up. So even though I checked the box, I said they were done, a month later, I'm still actually going back and just reinforcing that. So we've always found out that even though the habit may be built, you've got to continually reinforce it. You can't just forget about it because people will backslide. We also, not that we had to learn it, but it's been front and center. Healthcare's fractured. So one of the challenges that we really have is we try to really coordinate on behalf of those patients everything that's going on. So as we get to know our patients, we're trying to find out what are all of those other support programs that they've been enrolled in, whether they know it or not. Are they in a diabetes program? Are they in a COPD program? Are they in something else? So what we try to do is understand, all of those programs, and then we start actively reaching out to those companies again to just try to kind of make sure and kind of coordinate. Oh, wait a minute, your nurse for the diabetes is going to talk to you about this. So we can just reinforce it, but we're not going to, double dip, or your COPD program is going to do that. So one of our learnings is, again, very fractured. We don't have a great way of pulling all of that together. So we're still looking for a lot of solutions. Right now it's manual. It's really just consistently, calling and following up. And, we're even now trying to kind of take a look at some of the state HIEs, and are there ways of kind of pulling that information out there? And that's one of our other learnings is, we've had state level HIEs out there for 20 years now. They're extremely disparate and very different. And several of the states that we operate in, there's one state I'm particularly thinking about. I'm not going to throw them under the rug.
Yeah, no.
They have 5 different state HIEs, each with varying costs of anything from no cost to over $15,000.
Yeah.
Trying to connect into that is really difficult.
And I think that brings up something that I hear all the time. We talk about all the time, certainly as a clinician, is that health records, electronic health systems are great for compliance. They're great for billing. They're great for it to be a system of record, but they're not really always that great, nor are they built to be a system of understanding. And one of the things I was going to ask you is that, you take care of a lot of seniors. I think 1 in 3 seniors sees at least 5 different doctors in the course of a year. You mentioned how seems like you get very well linked in with primary care doctors, although I'd wonder with the guide program that, that's a different way people are coming into you. How do you manage that? But how do you manage across to really keep that visibility that you mentioned across all these different kind of healthcare providers?
Yeah, it's a great question and still a work in progress. So what we're trying to do is, again, the good thing is for us in the program that we're in, our documentation is not for billing purposes. It's really good. So that, again, Medicare's done a really nice job. So that allows us to actually really document, Greg is going to see Dr. Strimel, his cardiologist for this, and he's going to his allergist for that, or he's going to his infectious disease for that. So we actually have a record of that by using our nurse practitioners. Again, they're actually scanning it each and every time to kind of say, wait a minute, hey, you were supposed to go see your cardiologist. What happened? Let me explain it. Let me take a look to see if I can find the records and make sure that, you don't have any questions. So we're still doing a lot of that, really manually. But again, in our program, we're constantly asking the patient, constantly asking the caregiver, any new visits, anything new going on. Again, in the states that have more sophisticated HIEs, we are getting those alerts. We are pulling those down. So that actually helps, but still very much a manual process.
Okay, gotcha. Now you have a background in value-based care. I'll let you talk about that as much as you like, but I'm curious if how that played a role in you coming to embrace prevention care. What you saw, because value-based care is one of those things for decades, right? This is what was going to fix the broken healthcare system, and we still struggle with it, right? And it's really hard to get all the key stakeholders aligned. So, maybe if you don't mind, talk a little bit about what you learned when you were in that world and how that you brought that forward into this new model.
Yeah, and actually, take a step back. So, bringing into this model. So, I'm a pharmacist by education. So, spent a lot of my career, in pharmacy, both actually as a pharmacist, multi-unit manager, corporate operations. And in some ways dealt with the original capitated models back in the 90s and the early 2000s on the pharmacy side, which didn't go anywhere. But I then worked for a company called Oak Street Health. That really helped me understand how important primary care is to really keeping those patients out of the hospital. So it gave me a really good understanding of, what? At the end of the day, when you really want to look at costs, you got to look at hospitalizations. You have to look at prevention, which again, embrace prevention care. We kind of took those learnings. It's like, all right, you're going to deal with the acute, but how do you actually prevent it from happening? So we had a big focus on what's going to cause the hospitalization? How do you actually prevent it? If it does occur, how do you post-mortem it and really find out what happened and what could we have actually really done differently? So Oak Street Health was a great training ground for, how do you actually really start thinking differently? How do you start using that interdisciplinary team differently to be able to kind of pull together and leverage all the different people that you actually have at your disposal to kind of help out with those patients? So a lot of that went into our model as well, which is a lot of the upfront work, that we're actually doing with patients, really kind of getting them to change. And, again, we're taking a little bit of a different tactic. So Oak Street Health, they were very big on frequent visits. So that's actually how they were staying on top of their patients. What we're trying to do is do the frequent visits via telehealth, but really get the patients to take a little bit more ownership through their healthy habits. And that's a little bit of a fundamental shift. And we've probably taken the more difficult road, because we're
Sure.
actually
And then
trying to
involves
engage
the
patients, but
psychology right, changing people's behavior. It's very difficult.
very difficult. But when it happens, it's also remarkable on the outcomes. When you can get that patient to actually understand, what? I can actually get exercise. I can hydrate. I can sleep better. And then they start seeing the results. It starts feeding on itself.
Yeah, and Oak Street is probably one of the more recognizable names of a company that sort of went in and tried to say, okay, we're going to try to go in some level at risk, right, for this population of patients. And and I think that the goal there is if you're aligning incentives, right? If we do better, if the patients do better, we do better, and that's not always you would think that would be the case, right, in healthcare, but it's not. Of course, and so they bring in a lot of interdisciplinary stuff where in the traditional, let's say, family medicine, internal medicine, primary care practice, you're just getting paid for what you see, right? So you don't have that leverage to kind of do those additional things. But I wanted to link that to maybe, as much as you feel comfortable with talking about your business model, right? So how, you have these folks who are coming, sometimes you're working with PCPs, sometimes you're not through this Medicare program. Just, at a high level, how does this make economic sense for you guys?
Yeah. So, first of all, initially, through the guide program, we can pay for our costs. So what we get, what we receive from Medicare for, the patients in the guide program, we can actually cover our costs.
Okay.
We probably have the lower margins right now because we're using one of the highest level practitioners, as our, main person. So within the guide program, Medicare requires you to assign a person to the patient and the caregiver. They don't say who. So a lot of the models may use a medical assistant, they might use a social worker, community health worker, which is all completely fine. We've chosen to stay with our nurse practitioner led model because not only can we help with the dementia, but we're going to also manage the underlying chronic conditions. Again, to keep that patient with dementia, it's even more important to keep them out of the hospital because you don't want them to develop delirium in the hospital or anything like that. It just winds up being, much worse. So we can make our economics, but where we really want to go is to really get into shared savings programs. Take what we've learned around the hospital reductions, be able to prove that we can do that with these dementia patients, which do go to the hospital 42% more than traditional Medicare patients. And if we can do that, if we can show it with statistically relevant data, then what we're going to do is we're going to go back to the Medicare Advantage plans, because right now they're excluded from this program. So we'll go to the Medicare Advantage plans, we'll go to the ACOs and say, hey, look, you're all struggling with your MLR, here's an opportunity. And these are frequent flyers. So you don't really have that long term of I need to invest today, but I'm not going to see the payback for 5 or 10 years. You can invest today, and with these patients, because they are going to the hospital significantly more often in a year, they can start seeing the payback a lot sooner. So that's the plan. Right now, we need to be able to prove that. And, we expect to be able to start having those conversations in about a year and a half or 2 years when we have, several hundred to several thousand patients, within the guide program. And it's statistically significant at that point.
Well, if you are coming now from a place of reducing hospitalizations in a cohort of people with dementia by 40%, I have to imagine that's going to open a lot of doors for you.
That's our goal, and we're taking it one day at a time because we want to make sure that it's relevant. We want to make sure that it works, and at the same time, we want to make sure that people can get comfortable with what we're doing and how we're doing it. Because again, to get into some sort of shared savings relationship, there's got to be a trust on both sides. So we really want to do that. And, you know, what we're going to also do is, you kind of talked about it. We're going to wrap this around with our own proprietary system built by our nurse practitioners. So we're actually taking a little bit of a different approach. In fact, we've started it is so as we go through our workflows, they're actually being designed by our nurse practitioners. So it's not me, it's not the corporate, people that are actually driving it, the people who are fundamentally using our system. And it's really interesting to kind of watch what they value versus something that I would have valued on the corporate side. And again, we're just taking a little bit of a different approach because we want this to really be scalable.
I think that's such an important concept. And not all innovation is technology, but whether that innovation is technology or operations, often the forgotten person in that loop is the clinician. All these things get built by people who don't have to actually deliver the care, and they miss some key things. And in part, that's why I like having these conversations, because it's about linking clinicians and leaders and operators and technologists together so we can avoid that. Because I think they're getting better, but electronic health records are the prime example of this, right? That
Exactly.
they solve a lot of problems, but they weren't built for the people who deliver the care, and they've contributed a lot to burnout and things of that nature. So when you look out for the next couple of years, what are you excited about? What do you think is going to change, and what barriers are still going to be problematic?
Yeah, so I'm really excited for this guide model, the world according to me. So this is
Yeah,
100% my
over here.
statement. I actually truly believe that the pilot is going to end early and Medicare is going to open it up to everybody. I think that there's that much power in this model. And again, Medicare's done a really good job about enabling and removing a lot of the barriers. So I'm really excited for that. And it's personal. Again, my father had dementia. So the more that we can do for patients with dementia, the better off that we can be. So I'm really excited for that. It's going to still be a slog on the healthcare, information technology side. You have these big, massive systems, and I think there's two things that are competing. There's the desire to do something differently, and then there's just the inertia of, oh my God, how are you going to change some of these behemoth systems? So I think, in the out years, I think we will make incremental progress. I think it's going to take somebody in the market like really revolutionizing an EMR and kind of flipping the whole model on its head to say compliance is important, billing is important, but you've got to take it from a patient approach.
How do
And
we make
I think
use your phrase, how do we make it patient-centric, right?
yeah, I think there's going to be somebody, so I'm excited. I don't know who it's going to be, but I think there's going to be somebody breaking onto the market to be able to kind of, look at that, especially now that you got the fire standards out there, which is providing
Yeah.
additional flexibility. I think it's just going to take somebody to revolutionize that and say, you know what, there's got to be a better way.
Great. And how can people learn more about what you're doing?
So the easiest way, which I would tell people is, so this way they don't have to write it down, just Google Medicare Guide Program. Medicare has set up a great website which will actually walk through the guide program. They have all 300 or so of the participants listed by state, so people can actually find that out, or they can just go to embracepreventioncare.com. Either way, but anything that we do, we're promoting this guide program, and in every state that we're operating in, we always let our patients know it's like, hey, here's everybody that's operating. We may not be perfect for somebody, but what we want everybody to do is get linked up to the practice that makes sense for them.
And just for clarity's sake, so that's even like the patient, the family member, they can take themselves to the guide program. Is that correct?
That's correct. Yeah. And then when that happens, we will actually, again, getting back to, we will actually let the providers know, all of their specialists, to say, hey, Greg is interested. Here's the guide program. No break in your relationship. We'll keep you informed.
Well, Greg, this has been such a great conversation today. It's a problem that's not going away. You're thinking about it differently than I have seen. I can tell you, I operate around a lot of seniors and a lot of primary care. I don't see very much in the way of people taking this to really address the behavioral and the preventive steps from keeping people out of the hospital. And I can absolutely endorse, once someone lands in the hospital, a whole new set of risks comes in for the patient, the family, and the system. So thank you for the work that you're doing. Look forward to following along with you.
Thank you very much. I appreciate your time.
All right. And everyone, thank you for joining. I hope you enjoyed this today. If you are or your family members are dealing especially with things like dementia, look into the guide program. There's so many resources out there that people aren't aware of, and we love to highlight them here. And hopefully we'll see you the next time on the Healthcare Algorithm. And until then, be well.